I want to tell you about a patient that I met 4 times over the course of nearly 9 years. The first time I met her, we stabilized her. The second time I met her, we saved her leg, but only just. The third time I met her, we bought her more time. And the fourth time I met her, she died. And if I'm being completely honest with you, a large part of why she died, I believe, was because the healthcare system, including me, kept responding to the emergencies in her body without ever properly responding to the life that was creating them. She is one of those patients that never really leaves you. There are patients you remember because the medicine was interesting. There are patients you remember because the diagnosis was rare. There are patients you remember because the shift was chaotic or dramatic or traumatic. And then there are patients you remember because, years later, you realize they were trying to teach you something the entire time, and you only really understood it when it was too late. This patient is mine. And if this is the first video you're watching from me, then welcome. I'm Dr. Michael Carter. I've spent years working in acute and emergency medicine, and somewhere in the middle of that career, I changed completely how I think about what a doctor's job actually is. I used to think that my job was to diagnose fast, intervene well, prescribe correctly, and move on to the next patient. Now I think that's only a tiny part of the truth. Now I think that if all we do is rescue people at the point where their disease becomes dramatic enough to be seen on a scan, or measured in a blood test, or wheeled through the doors on a trolley, then we are arriving far too late. And this is basically the story of why I came to believe that. So I first met her in my 3rd year as a doctor. She was 41 years old, and she came into the emergency department late one evening, complaining of exhaustion, thirst, blurred vision, and this horrible heavy feeling in her body that she couldn't really put into words. She said she'd been feeling unwell for months, but she had put it off and put it off and put it off because she was busy, because she was working, because she was looking after other people, because she thought she was just tired. And that sentence alone probably describes half the people we see in medicine. She was the sort of person who had made herself the least important person in her own life for so long that by the time she turned up to hospital, her body had been quietly sounding the alarm for months. When I took a proper history, the story became obvious very quickly. She'd been getting up multiple times every night to pass urine. She'd been drinking water constantly and still feeling thirsty. She'd lost weight, but not in a healthy way. She was exhausted all the time. Her vision had gone blurry, and she kept saying this line to me that I still remember almost word for word. She said, "I know this sounds ridiculous, doctor, but I just don't feel like I'm properly inside my own body anymore." Now, when somebody says something like that, you know before the blood tests come back that something significant is going on. We checked her blood sugar almost immediately. It was extremely high. We sent off the rest of the bloods, checked her ketones, got fluids started, and within a very short space of time, it was obvious that she had severe, uncontrolled diabetes that had been building for a long time before anybody had really caught it. Now, technically, what mattered in that moment was that we treated the crisis. And we did. We gave her fluids. We started bringing the glucose down safely. We monitored her bloods. We got the medical team involved. We explained the diagnosis. We got her admitted. All of that was appropriate. All of that was necessary. But what I remember most clearly is not the medicine. What I remember is sitting on the edge of that cubicle while the fluid ran through the drip, and looking at this 41-year-old woman who looked far older than 41 because life had clearly been hard on her, and thinking that this was not really a diabetes story at all. This was a life story. This was a stress story. A sleep story. A food environment story. A shift work story. A single parent story. A money story. A shame story. And I remember wanting to ask her all of it. I wanted to ask her what her days actually looked like. I wanted to ask her what she was eating, and whether she had time to cook, and whether she ever sat down for a proper meal, and whether she was sleeping, and whether anybody was helping her, and whether she spent her whole life running on caffeine and convenience food, and adrenaline, and responsibility. Because if we're honest, that is where a lot of chronic disease actually lives. It doesn't begin in the prescription pad. It doesn't begin in the lab result. It begins years earlier, in the structure of somebody's ordinary life. But I was a junior doctor in a packed department, and the message I got, not cruelly but very clearly, was that this was not the place for that conversation. The job here was to stabilize. The ward team would continue the treatment. The diabetic nurses would educate her. Primary care would follow it up. Community services would support her. That was the theory anyway. So I did what doctors are trained to do. I sorted the immediate problem. I documented carefully. I handed over. I moved on. And before she went upstairs, I remember explaining to her that this was serious, that she would need ongoing treatment, that this wasn't something to ignore. And she nodded in exactly the way people nod when they are overwhelmed and frightened and trying very hard to appear calm. She was started on medication. She was given the usual information. She was eventually discharged. And I didn't speak to her again during that admission. 3 years later, I was working in a different hospital. Busier department, bigger city, more pressure, more noise, more patients. More of that strange hospital rhythm where everybody is doing 10 important things at once, and somehow it still never feels like enough. And a patient was brought into the department with a badly infected foot. Before I had even properly read the notes, I recognized her. She was only 44 at that point, but she looked exhausted, in a way that went far beyond being physically tired. She looked worn down, defeated. Like somebody who had been trying to keep too many plates spinning for too long and had finally run out of hands. The infection had started as a small blister, apparently. That is how these things often begin. A little bit of rubbing from a shoe. A patch of skin that breaks down. Reduced sensation in the feet because long-standing diabetes quietly damages the nerves. A wound you don't fully notice. Then infection. Then spreading redness. Then swelling. Then pain, then fever, then suddenly something small becomes something that threatens a limb. When we examined her properly, it was obvious this was serious. The infection had gone deep. Her blood sugars were all over the place. Her inflammatory markers were through the roof, and the wider picture was already becoming visible. This was not a one-off complication. This was what happens when chronic disease is allowed to keep rolling forward year after year. So we did what we do. We started IV antibiotics. We got the surgical teams involved. We controlled the pain. We monitored her closely. We started dealing with the immediate danger. And while I was taking her drug history, I asked her about the diabetes medications she had been started on years earlier. She hesitated. Then she said she hadn't been taking them properly for a long time. Not because she didn't care. Not because she was stupid. Not because she was reckless. But because life had become unmanageable. She said that for a while after the first admission she had tried. She had genuinely tried. She had gone home scared enough to take it seriously. But then work got hectic again. Money got tight. Her mother became unwell. Her son started struggling in school. She was sleeping badly. She was eating whatever she could grab between responsibilities. Appointments were hard to get to. Different clinicians told her different things. One person told her to avoid sugar. Another told her it was about calories. Another told her it was about weight loss. Another adjusted medications without really explaining why. She said every appointment felt like she was being measured and quietly judged. And eventually, like many patients do, she started avoiding the very system that was supposed to help her. She said to me, very calmly, "I know I've done this badly." And I remember feeling something sink in my chest when she said it, because that sentence told me everything about how she understood her illness. She thought the problem was that she had failed diabetes. She didn't realize that the system had largely failed to make health feel possible in the middle of her actual life. There is a massive difference between those two things. A patient who does not care looks one way. A patient who is ashamed looks another. And shame is one of the most medically destructive emotions I have ever seen. Because shame makes people hide. It makes them cancel appointments. It makes them stop asking questions. It makes them nod, as if they understand. It makes them pretend they're doing fine. It makes them disappear until the problem becomes so serious that hiding is no longer physically possible. That admission was rough. There was talk of surgery. There was a very real concern that she might lose part of her foot if the infection didn't come under control. And I remember again feeling that pull to sit down and talk to her properly. Not just about antibiotics and wound care and tablets and follow-up, but about the architecture of her life, about the fact that her disease was not living in isolation. It was being fed every single day by stress, poor sleep, chaos, ultra-processed food, low movement, no recovery, no support, and a level of sustained pressure that would have broken most people. I wrote in her notes that she needed proper diabetic education, continuity, support, review, and somebody to spend real time with her. I handed over that concern clearly. I really believed, or maybe I wanted to believe, that somebody further down the line would finally have that bigger conversation. But within a day or two, she was under another team, then the weekend happened, then discharge planning took over, and the whole machine moved on. The infection improved enough. The crisis settled enough. The danger reduced enough. And in hospital medicine, enough is often the threshold at which the system stops looking at you closely. That is one of the truths that people outside medicine don't always appreciate. We are often not returning people to health. We are getting them just stable enough to survive outside the building. There is a huge difference between those things. I thought about her for a few days after that, then a few weeks, and then, like with so many patients, the pace of medicine carried me onward. Until I saw her again. The third time I met her was about 4 years later. By then I had worked in different hospitals, different systems, different departments, and I had become, I think, both more clinically competent and more emotionally disturbed by what modern medicine often is. Because the more experienced you get, the more patterns you see. And once you see the pattern, you can't unsee it. This time she came in breathless. She was 48 years old. Still far too young to look the way she looked. Still far too young to have the medical history she now had. The diabetes had marched on. Her kidneys were failing. Her blood pressure had been poorly controlled for years. She had significant nerve damage. Her vision had deteriorated badly. She had swelling in her legs, fatigue that dominated her life, and that look that some patients have where you can tell they are carrying their illness every minute of every day. She didn't arrive dramatically this time. No flashing lights. No huge emergency entrance. No single cinematic moment. And in some ways that made it worse. Because this was not one big catastrophe. This was slow-motion damage. This was what it looks like when a body is steadily worn down over years. We admitted her again. We managed the fluid overload. We adjusted medications. We got specialists involved. We talked about kidney function, blood pressure targets, glucose control, future risks, all the language of modern chronic disease medicine. And this was the first time I really got to sit with her for more than a few fragmented minutes. Not long enough, but longer. And I asked her a question I should probably have asked years earlier. I asked her what living with all of this had actually felt like. Not the symptoms, not the medications, not the numbers, the experience. And she gave me an answer I don't think I'll ever forget. She said, "It feels like every doctor sees a different part of me, but nobody sees my life." That sentence hit me like a punch. Because it was true. The foot team had seen the foot. The renal team had seen the kidneys. The medical team had seen the blood sugars. Primary care had seen the blood pressure. The eye clinic had seen the retina. But who had ever really sat down and said, "How are you living? What is making this impossible? What would change actually be possible for you? What support do you need? What habits could we build that you could sustain in the real world you live in?" Very few people, if anyone. And then she said something else. She said, "I always felt like I was being handed more instructions than help. That is such a precise description of what healthcare can become. More leaflets, more warnings, more medication changes, more targets, more appointments, more numbers, but not necessarily more help, not necessarily more understanding, not necessarily more capacity, not necessarily more hope. And I remember leaving that conversation with a level of discomfort that was much deeper than normal guilt, because this was no longer just about one patient. I had started seeing versions of her everywhere. Different disease, different age, different postcode, same pattern. We wait until somebody's health breaks loudly enough to be undeniable. Then we intervene. Then we discharge. Then we hope. Then we act surprised when they come back sicker. And all the while, we speak as if the solution is just better compliance, better adherence, better motivation, more discipline. As though people are failing health, rather than health being designed in a way that fails ordinary people. She survived that admission too. But by that point, if I'm honest, surviving felt like an increasingly temporary word. Because what we were really doing was slowing down the collapse, not reversing its direction. And then came the fourth time I saw her. It was just over 2 years later, on a night shift. She was 50. She was brought in by ambulance. And before I had all the details, before the notes had even caught up properly, I knew this was bad. She had been found collapsed at home. The paramedics had managed to get a pulse back after a brief arrest. She was critically unwell. Her blood pressure was unstable. Her breathing was poor. There were signs of overwhelming infection, severe metabolic derangement, and multi-organ failure on a background of years of disease that had already taken too much from her. The room filled very quickly. Monitors, bloods, access, fluids, pressors, escalation, calls to intensive care. Everybody doing what they are trained to do when a human being is slipping away in front of them. And to be clear, none of that was meaningless. This is the part of medicine that is extraordinary. When people are critically ill, modern medicine can be astonishing. Skilled people moving fast, thinking clearly, doing difficult things under pressure. I will never stop respecting that. But as I stood there watching the team work, all I could think was that we were meeting her at the very end of a chain of failures that had begun years earlier. Not one failure, 1,000 small failures. Missed conversations, rushed reviews, no continuity, no one owning the bigger picture, no one with enough time, no one with enough authority, no one with enough space in the system to say, stop, this woman does not just need more prescriptions and more warnings and another follow-up in 6 months. She needs a completely different level of support before this disease takes everything from her. We got her to intensive care. For a short while, it looked as though she might pull through, and then she didn't. She deteriorated rapidly. And later that same day, after every escalation that was appropriate had been tried, she died. I spoke to her family afterwards. And if you have worked in medicine for any length of time, you will know there are conversations that stay in your body long after the words are over. This was one of those. Her daughter said something that still comes back to me regularly. She said she always felt like she was being patched up and sent back out. Patched up and sent back out. That is such an unbearably accurate description of what medicine can become when it loses sight of prevention and context and actual human support. Her family talked about how overwhelmed she had always been, how she wanted to do better, how she would have these moments after every hospital admission where she would be frightened enough to want to change everything, and then real life would close back in around her like it always did. Bills, work, fatigue, caring for other people, bad sleep, stress, no time, no energy, no confidence, too many conflicting messages, too much shame. And slowly, steadily, the urgency would fade until the next crisis forced it back into focus. And I sat there listening to them and thinking about all the points in those 9 years where her trajectory might have been altered. Maybe not perfectly, maybe not completely, but meaningfully. at diagnosis, after the second admission, at medication review, at every missed prescription, at every hospital discharge, at every point where another complication appeared. How many chances had there been to intervene differently? How many opportunities had there been to stop treating her disease like a series of isolated technical problems and start treating it like a whole-life emergency? That is the phrase I keep coming back to, a whole-life emergency, because that is what it was, and I include myself in that failure. I was not the only doctor involved. I was not the main doctor involved.
I was not solely responsible. But that is not really the point. The point is that I saw what was happening long before she died, and like so many of us in medicine, I trusted that the system would eventually do the humane, thorough, preventative thing.
That someone else would pick it up. That somewhere along the pathway, the right conversation would happen. That someone would have the time. That someone would join the dots. That someone would build a bridge between the medicine and the life. But when responsibility is spread thinly across enough people, it often evaporates entirely. When something belongs to everybody, it very quickly belongs to nobody. And what broke something in me about this patient was the realization that we are incredibly good at discussing what to prescribe after disease appears, and embarrassingly poor at helping people build lives in which disease is less likely to flourish in the first place. If I had my time again, and I genuinely wish that I did, I would approach her completely differently from the start. Yes, I would still treat the emergency. Of course I would. Yes, I would still prescribe the medications that were necessary. Of course I would. But I would never again allow those things to feel like the main event. The main event should have been building the foundations. I would have sat her down and said, before we talk about medications, I need to understand your actual life. How are you sleeping? What do your mornings look like? What do you eat on the days when everything is hectic? How much of your food is convenience because you're overwhelmed, not because you're careless? Do you have time to walk? Are you moving at all? What is your stress like every single day? Who are you looking after? Who is looking after you? What support do you have? What can you realistically change this week? Not in some fantasy version of life, but in your real life. Could we get you eating more whole foods most days, rather than chasing perfection? Could we build regular meals around protein and fiber so your blood sugars are not on a roller coaster all day? Could we reduce the liquid calories, the constant snacking, the late-night eating that comes from exhaustion? Could we get you walking after meals? Could we start some basic resistance training so your muscles become a better place for glucose to go? Could we improve your sleep, because poor sleep wrecks appetite, blood sugar, energy, mood, and self-control all at once? Could we lower the chaos enough that your biology has a fighting chance? That is the conversation I wish she had been given. Not once, repeatedly, supportively, without shame, without jargon, without pretending that a leaflet is the same thing as help. Because this is the truth, that medicine does not always like admitting information is not the same thing as transformation. Most patients do not need one more lecture. They need a plan that fits inside their real life. They need repetition. They need encouragement. They need follow-up. They need the basics explained clearly enough, and often enough, that it actually changes what happens on a Tuesday when they are tired and stressed and hungry and short on money and one bad decision away from slipping back into the same routine. This patient changed my career because she made it impossible for me to keep pretending that prescribing well is the same thing as healing well. It isn't. Prescribing matters. Emergency medicine matters. ICU matters. Specialists matter. Drugs can save lives. Procedures can save lives. Hospitals can save lives. I have seen that with my own eyes more times than I can count. But none of those things can build your daily habits for you. None of those things can sleep for you. None of those things can walk for you. None of those things can eat for you. None of those things can regulate your stress for you. None of those things can create margin in a life that is packed wall to wall with pressure. And yet those are exactly the things that often determine whether somebody becomes chronically ill in the first place and whether they stay trapped there. So one of the biggest lessons I want people to take from this story is this. Do not build your understanding of health around the fantasy that a doctor will sort it out later. If you break your leg, absolutely go to hospital. If you get crushing chest pain, absolutely call an ambulance.
If you are seriously unwell, modern medicine can be life-saving. But in the years before any of that, in the ordinary quiet seasons of life when disease is slowly being built or slowly being prevented, your health is shaped far more by what you repeatedly do than by what we eventually prescribe. Every day, that is the uncomfortable truth. Doctors can often prevent death. We are much less able to create health. Health is mostly built at home, in kitchens, in supermarkets, in bedrooms, in gyms, on walks, in friendships, in routines, in what you do when nobody is watching and nothing feels urgent yet. And that is why this patient changed my entire career forever. Because after seeing her story unfold in 4 separate chapters over nearly a decade, I could no longer convince myself that the most important work in medicine happens inside the hospital. Some of it does, yes, but the deepest work happens before the ambulance is ever needed. It happens upstream, and I started talking about these things publicly because I became convinced that there are millions of people living like she was living, not because they are lazy or stupid or irresponsible, but because the modern world makes illness easy and health inconvenient. And then, when the consequences arrive, we medicalize the aftermath and call that care. That is not enough. It was not enough for her. And if we are not careful, it will not be enough for a lot of other people either. Every day has patients they carry with them. Patients whose names they may not say out loud very often, but whose stories change the way they practice forever. This patient is one of mine. I still think about all the things I wish I had said earlier. I still think about all the times I assumed someone else would have the conversation. I still think about how many admissions looked medically successful in the short term and were actually signs of a long-term failure none of us had properly interrupted. And I think that discomfort is useful. Because sometimes guilt, when it's faced honestly, becomes clarity. And that clarity for me was this. If I really wanted to help people, I could not keep speaking only at the point where disease had already become advanced enough to need a hospital bed. I needed to start speaking much earlier. About food, about movement, about muscle, about sleep, about insulin resistance, about stress, about habits, about prevention, about the daily behaviors that feel boring compared with emergency medicine, but quietly decide an enormous amount about how our future goes. So if there is one thing I want you to take from this story, it is this. Please do not wait for the big scare. Do not wait for the diagnosis to make health feel relevant. Do not wait until your body is shouting before you listen to the whisper. Because by the time disease is dramatic, some of the damage is already done. Start now. Start imperfectly. Start with walking more. Start with eating more real food. Start with sleeping properly. Start with building strength. Start with reducing the things that you already know are hurting you. Start with consistency instead of intensity. Start with the understanding that your future health is not created by one dramatic rescue, but by hundreds and thousands of ordinary choices repeated over time. That is the lesson buried inside this woman's story. And in a strange way, it is also the reason I'm here talking to you now. Anyway, thank you for listening. I'm Dr. Michael Carter. If this helped you think differently about your health, or about someone you love, then share it with them.